This is Dr. Lauterbach, and this is the mini lecture for week 13 and our final mini lecture of the course. We finish with chapter 22, which is about health promotion and palliative care. By way of introduction of the topic, the authors note that there's an increasing attention to palliative and end-of-life care in health promotion. The prevalence of individuals with chronic conditions in the United States is increasing, and there's a concentration in the United States of healthcare spending in the last months of life. They also point to a global impact of serious illness and chronic disease as rationale for why we need to be more attentive from a health promotion perspective when we're talking about palliative care. They make the point that palliative care is an essential part of nursing, and part of their argument for that hypothesis or proposition is that it dates back to Nightingale in the Crimean War. The authors point to the development of palliative care in nursing education. There are some end-of-life nursing education consortium initiatives. There is widely varying coverage, meaning insurance coverage for palliative care, although it is becoming increasingly recognized, I think, by most major payers. And then they refer to the National Consensus Project for Quality Palliative Care, which is published in 2018, and they talk about 8 palliative care domains, although they don't actually tell you what they are, so I'll tell you what they are. The first one is physical domain, followed by psychological domain, social domain, spiritual domain, cultural domain, ethical domain, caregiver domain, and bereavement domain. The authors talk about definitions of palliative care. They include a philosophy and a healthcare specialty for nursing and varied disciplines, organized system of whole person focused care for individuals with serious or life-limiting illness and their families, a focus on fostering quality of life and well-being for family and individuals and their families, and it is appropriate focus at primary, secondary, and tertiary palliative care levels. Most of us, I think, have been made to think that palliative care is about care that's not curative in nature. And I think that that definition, although broad and not very specific, is true and is consistent with these other definitions that you see here. Palliative care has been ongoing in development, starting really in the early works of Kubler-Ross back in the 70s, and the hospices of Great Britain, really where it all started. We now see evolution and growth both in education and in services, and recognition by certifications and research and policy initiatives. But there remain gaps. There's a lot of limited or wrong information about services, insufficient services to meet the growing need, disparities in the care people receive, and a need for additional research. They point to a mismatch in the growth between the number of people who would benefit from primary, basic, or secondary specialized palliative care, as well as the availability and accessibility of such services. This gap is a public health crisis. Efforts to align palliative care and health promotion can contribute toward meaningful progress in the overarching goal of promoting quality of life and well-being across life stages. So, what would that look like? Well, the development of health-promoting palliative care initiatives are ones that support improving individuals' own health advocacy and engagement in services, advancing public policy, and fostering social and healthcare environments that support health, community action, and personal healthcare management and communication skills. That comes from the World Health Organization 2017. A lot of the health promotional focus for palliative care comes around advanced care planning and advanced directives, and the importance of starting that early and not late in the cycle of a lifespan. And they point to the importance of advanced care planning with three basic elements, and they are: advanced care planning is a process that supports adults at any age or stage of health in understanding, sharing their personal values, life goals, and preferences regarding what they want for future medical care. The second is the goal of advanced care planning to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. And thirdly, for many people, this process may include choosing and preparing another trusted person or persons to make medical decisions in the event that they can no longer make their own decisions or express their own decisions. There is widely a problem with limited understanding and completion of advanced care planning and advanced directives among the population. It's often not brought up, it's very infrequently discussed. There was an initiative I remember back probably around 2015, maybe a little earlier than that, where at every hospital admission, we were required under payer rules and quality guidelines to ask everybody if they had an advanced directive when they came into an acute care hospital stay. That may still go on, I don't know. It was well intended, but it didn't produce, I think, the outcomes we were hoping for. What it did produce was surprise to people while they're anxious. It elevated anxiety. I'm not sure it ever led to more advanced care planning or advanced directive creations. But it did upset a heck of a lot of patients. I do remember that. So, the place for this to happen, I think, is twofold. One, on an individual basis, it would happen between your primary care provider and the person or family. Early on, a discussion about that should be included. And I would tell you that in my own area where I practice, we don't talk about this. And it's a gap that we need to address. And I think it needs to be addressed many places. My primary care provider has never talked to me about this. So that's on the individual basis. But on a broader basis, this is a very legitimate thing in terms of health promotion to talk about advanced care planning, what it means in community groups, and not only seniors community groups, but at all ages, because even when people are early in their life and not expecting to have serious illness in their near future, many of them are connected to older people who are at a point in their lives when they're ready to start that discussion, because the awareness of their end of their own life is coming into clearer focus. So this is a really valid place for health promotional activity to ultimately, in the future, improve somebody's quality of life. They refer to some recommendations for further improvements from the American Academy of Nursing's Palliative and End-of-Life Care Panel, and they included encouraging individuals to articulate their advanced care planning preferences, improving reimbursement for advanced care planning and directives, communicating information via centralized and electronic health records, and improving interprofessional healthcare professional education and training. That middle one, communicating information by centralized and electronic health records, that has to ride along with a much bigger nut to crack in terms of information systems, and that's interoperability. We're starting to see more, but it still has a long way to go. Where if you are, as we talked about, with patient portals and different things a few weeks ago, if you're connected to one health system on one platform, that information may or may not get connected to another one. Now, I'm familiar with Epic more than some of the other major ones. They have just recently have a thing called Care Everywhere, and that everywhere only means other places that use Epic. So if I'm caring for somebody in a Beaumont hospital, Corwell hospital, forgive me, on Epic, and I want to find out something that happened to them at, say, the Henry Forward Health System, which is also in Epic, I can use this application within the Epic platform called Care Everywhere, and it will go out and search for specific types of information that I ask it for. Now, some of it, of course, behavioral health records, different things will never be in Care Everywhere, but it's a start. We need the same thing with advanced care planning because you could do a lot of advanced planning and advanced directing, but if the episode happens that you are in a serious state and are not able to tell anybody about this, you may show up without your designated person, and your providers just won't know that these documents exist. So this is a really important one, but it's going to take some more work on interoperability. The authors postulate that nurses' role is critical in advanced care planning and advanced directives. I don't know that any of us would disagree. They do suggest they incorporate nicely the trans-theoretical model or stages of change model into figuring out how to have that conversation, when to have the conversation, how to get it started. And that is oftentimes some of the most difficult part of talking about difficult subjects, whether that's obesity and how to manage it, or sexual health risks. And, I would throw advanced planning into that mix. People don't want to talk about their ultimate demise as a rule. I mean, I shouldn't say they don't. It's an area that can needs to be discussed in a way that is sensitive and open and thoughtful by the provider about what does the client want here. So I would say trans-theoretical model, but also very much motivational interviewing. I'm talking to patients about these things, and I have some information. Would you care to hear it? Is a really good way to start the conversation, and to bring it up periodically until the person says, yeah, I'd like to engage in that conversation with you. Conclude for this chapter the key points of health promotion palliative care out of this chapter and in general are: primary palliative care can be integrated into care early, even before a serious illness diagnosis has been made. Advanced care planning and advanced directives are important aspects of health promoting palliative care. Resources are available, and they list many of them in the chapter, to meet a wide range of learning styles and needs. And as we have heard all semester long from the authors, more research is needed. And that concludes today's mini lecture.